I would like to invite our last speaker, Dr. Jitendra Jethani. He'll be talking about myopia management guidelines and best practices. Dr. Jitendra.
Thank you so much, sir. Thank you. Thank you, AIS, for giving me the opportunity to speak on myopia management guidelines. I think all the previous 4 speakers have made things pretty easy for me. I just have to talk about summarizing what has already been discussed extensively and very nicely by the previous speakers, be it Dr. Kaushik, who spoke about the risk factors, and Dr. Vivek, who talked about the pharmacological option, and Dr. Sandra, she talked about, so all this has been, all of these things have been discussed. It's very easy to skip this because this is what we want to do. We want to correct and control the myopia. So this is step 1, which I will be borrowing a lot of things from Dr. Murli's presentation. So history is very important. These are the risk factors. Younger the age at which myopia strikes, we should be more cautious because these patients are typically non-responders to the treatment. Typically they progress faster. If there is a history of parental myopia, sibling myopia, this is very good red flags. We can pick up pre-myopes when you have one kid already there with myopia, you can always pick up the other kid quickly. Ethnicity, we already saw from Dr. Murli's presentation. As we go towards eastern part of the globe, we have more tendency to progress and prematurity. This is different from what we normally see. So we have to see whether there is axial elongation in these prematures or not. So typically this prematurity and myopia is a totally different ballgame from what we are treating at this point of time. Lack of outdoor timing, excessive near-based time, and history of fast progression. These are all the risk factors. This is just to summarize it. He has taken it extensively. So it was a very nice presentation. Then we move on to the part 2 of diagnosing and analysis. So the first part, most of us do. We do cycloplegic refraction, which is mandatory. When we typically check a kid with myopia, we should not be over-prescribing them. And baseline keratometry and baseline axial length. These are the key to finding out whether the progression is because of axial growth or because of some other changes going on at the corneal level. Fundus evaluation is a must, and pachymetry. So who is the progressor and who is actually progressing? So all this gamut, all this discussion is on progression. We are not here to reduce the prevalence of myopia. We are here to curb the progression because we know that each diopter increase in myopia ends up into having long-term complications of glaucoma, peripheral myopic degeneration, and many other problems. So myopia progression is defined as a progression of glass power by around 0.5 diopter over a year. In terms of axial length, it is variable. Some people take a cutoff of 0.2 millimeter. In our clinic, this is what we do in our clinic. We take 0.2 millimeter over an year for children above 14 years because typically after 14 years, the growth is not much and it is almost stabilized. So if you still see a growth, that means the kid is progressing, and 0.3 millimeter under the age of 14 years, and there should not be any changes in the ocular biometry. So I have kept a small subgroup of pre-myopes. They are not typically myopes, but they are like very small myopes or really hyperopes or emetropes who may have risk factors or who may be abnormally moving towards myopia. So I would also recommend that if you have kids whom you feel that they are at a risk of myopia, we should do axial length for those patients also. So pre-myopes who are non-progressor, nothing is to be done. Only we have to remove the risk factors. What are the risk factors? Reduce daylight timing and outdoor activities near work. So this is what we have to do for non-progressors. We don't have to jump to the gun. Pre-myopes, if they are progressors, may need some myopia management strategies. Most important is environmental modification, behavioral modification. These are key to the success for myopia progression control. If there is a myopic progressor, you can do a peripheral refraction. We have been talking about it since last couple of days, and we have understood that whether there is peripheral refraction or not, you can still go ahead with whatever is your combative strategy. Accommodative lag with MEM method, behavioral modification, and 2 options. One has been discussed, as low concentration atropine, because all pharmacological modification ultimately come down to low concentration atropine, and optical mainly are myopia control glasses. Low concentration atropine, we had a wonderful talk by Dr. Vivek. These are some of the guidelines which we do in our clinic. So that is what I am saying. I consider it as a first line, mainly because of cost, of course. And so what we do is we typically first find out whether it is a myopic progressor or not, and then we start atropine 0.01% once at night, and we follow them up at 1 month, just to see whether they have any problems with that, whether the pupil size is increased or not, whether they have problems in near work or not. So in our work, we found that almost 95 to 96% of kids had absolutely no problem with 0.01%, but you have to keep an eye open, and they may have allergy, because it is at the end of the day a sulfa drug. And then after 3 months, and then again after 6 months, typically we wait for 6 months for any progression. We don't wait for a year. We are a little more aggressive in these terms. So we wait for 6 months. We keep on checking axial lens. Myopia progression has slowed down. Then we don't increase the concentration, or we don't make it twice a day. But if the progression has not slowed down to even 50% of it, then we may think of increasing the frequency. And then if you have a defined non-responder, you know that this patient is not responding to low concentration atropine, we may jack up the dose. Again, once you increase the dose, you have to call the patient back after 20 days or 1 month to see whether the pupil has dilated or there are any other accommodation related problems. So what to do, follow up after 1 month. This is the list of what we do at the end of 1 month, at the end of 3 months, at the end of 6 months, and then we continue to follow them at 6 months. Peripheral defocus lens, excellent talk by Dr. Sandra. She talked at length about what is MyoSmart and what is Hall, what is Care. DOTS is not available right now in India. It is mainly based on diffusion optics technology, where they change the contrast, but these 3 lenses are available. And peripheral defocus lenses, also we call the patient again after a month. We have seen patients in whom they complain that they are not able to see clearly when they are in open areas or when they are playing. So we do tell them that they can wear single vision lenses, because they are not really at risk when they are actually outdoors. Some patients do find it difficult to have a peripheral visual field, because there is a clear central 9 millimeter zone which accounts for 30-degree field. We did visual field analysis for these children, and we found that in the central 30-degree there were no scotomas. So once they have a good fit, everything is fine. We call them after 6 months, and we follow them up with the same set of investigations that we did at baseline. Now, myopia management guideline, this is the summary of most of what I have been talking about. And I would still say that behavioral recommendations are at the top of the list. No treatment will work without outdoor activity, without reducing the near work. So that is very, very important, and that is a crux of the whole myopia management guideline. The first part takes care of the history part, and then evaluation, categorization and recommendations on pre-myopes and myopes. And then there is about myopia progression and what we do at first follow-up at 1 month and follow-up every 6 months. So that is regarding the guideline. Thank you so much for the time.
Thank you, Dr.